Hi, my name is Caleb Graham, and today we are going to be discussing the genetic disorder that I picked for this class. I chose critical congenial heart disease, um, and I chose this because it hit close to home as far as having family members that have been diagnosed with some form of heart disease or heart defect, as well as having a son that was born with a heart murmur, which falls under the CCHD platform. So today we're going to be discussing, a few topics. What is CCHD? Some physical effects and symptoms, as well as some, basic topics that go under this platform. Mode of inheritance, go over a little pedigree chart, and then discuss a little bit about the genetic mutations and some genetic testing. To start, we are going to discuss what is CCHD. So critical congenial heart defect or heart disease is any aspect of the heart that is abnormal. So it could be anything as far as your valves, your veins, your arteries, anything going in and out, and then just their overall structure. So it could be a lot of different things. This is an important topic because the heart is responsible for so much of the body, keeping it living through blood flow and oxygen dispersal throughout the body. Without this, organs and tissues would greatly suffer, and in return, the patient would also suffer. It can cause death if not treated, but most of the time, if treated at a young age, they'll be able to pull through it. Next topic is major characteristics. So fun fact is that 30% of infants deaths come from birth defects, and the most common one is CCHD. In the U.S. back in 2019, 7,200 infants were diagnosed. I'm sure as technology keeps increasing, we're able to detect things during pregnancy, and then after birth, we'll be able to, I'm sure that number is going to increase as time goes on. But that was from the CDC. Most cases that are identified at birth, so once the baby's born, they'll run all of the normal tests and see if anything's abnormal with that heart. And then if so, surgery in worst cases, or if not, just monitoring it lets the doctors know and the patient, parents, and all that know what's going on instead of just being blind going in the future. People that are not diagnosed and go years without knowing, they are at greater risk as far as organ failure or possibly death. Physical effects of CCHD, we talked about a little bit, is anything in the valves, any aspect of the heart, whether it be the four chambers, the vesicles, the arteries, any abnormality. And sooner the better. Can be fixed by surgery. That would be the best thing. Symptoms. Some people experience symptoms, some people don't. If a patient does not and catches it later in life, that's obviously the worst case scenario. But some symptoms that fall under CCHD are fluid in the lungs, heart murmur, shortness of breath, abnormal heart rhythm, whether it be too fast or too slow, and cyanosis, which is bluish or purple of the skin, which means, a lack of oxygen, a lack of blood flow, and this is going to cause that pigment change in the skin. Mode of inheritance, it's described as random. So there's not one specific, either it be autosomal dominant or autosomal recessive, or even, sex linked. There's nothing cut in stone as far as that is. So it's totally random. If someone in your family does have it, it increases your chance of having it, but it doesn't mean that you are going to have it. But if no one in your family has it, then your chances are a little bit lower of you, developing CCHD. This is a basic pedigree chart, just to show an example of autosomal dominant. Here we have the red indicates CCHD patients that are affected, and since it is dominant, any patient that is infected, they're going to have that. Since it is dominant, you're going to see here that every generation has CCHD present. That is the first telltale sign of being autosomal dominant. If it's going to skip a generation, what we don't see here, then it would be classified as recessive. There's a couple cases down here that shows you that parents, if one parent has it, one parent doesn't, the kids have a chance of not having it as well. So it doesn't mean it's going to just spread throughout the family. The next slide we're going to talk about is genetic mutations. One protein that we talked about is NK2, and this just helps regulate the heart morphogenesis, and it's the major part of transcription during genetic and basic functions and development of the human heart. More genetic mutations for NK2. There's some examples here with arterial septal defects, some ventricle septal defects, double outage with the right ventricle and interruption of the aortic arch. And that comes from Chung and Radakumar in 2016. Some examples of genetic testing that could take place. Since it is an FDA standard, testing can happen either while they're pregnant or when the patient's born. So they can do DNA testing, fetal ultrasound at 18 to 22 weeks, fetal echocardiogram 20 to 22 weeks, and some DNA testing where they take out some embryonic fluid and test that. Controversy, there could be a little controversy, but for the most part it's a standard. So if patients want to know if they have the potential of having CCHD or if they don't. So I guess everything with genetics comes with some sort of controversy. So a controversy could be extracting DNA while the baby's still in the womb. Not every, it does come with some risk. Nothing's 100% safe, but that would be a controversy that I would think would come up if you're wanting to test for this disease. And there's some references that we've talked about today and where I pulled my information. So thank you for listening, and have a good day.